Hello everybody, my name is Geert Meyfroidt. I'm from Leuven in Belgium. And in this talk I will try to explain you how I manage intracranial hypertension, or maybe I should say how we manage intracranial hypertension, because I will present part of the CIVIC guidelines to you. These are my disclosures. None of them present conflict of interest for this talk. So as we all know, when it comes to neuroprotection, we don't have a magic drug or a magic agent. And so actually the only thing that we can do, and I'm saying the only thing, but it's already a lot and a lot of work, is to try to maintain adequate oxygen delivery while modulating oxygen consumption in brain injured patients. And we have to do this 24/7, so we cannot have a couple of hours of lousy control, because we risk to damage the brain in that period. And one of these very important parameters we follow in acute brain injury is the intracranial pressure. And we do this for two reasons. One reason is that we want to detect impending herniation. And the other reason is because we want to use this signal to optimize perfusion. Now, when it comes to treating elevated intracranial hypertension, we do a lot of interventions, and this can be from mild sedation, intubation and ventilation, interventions that are considered as relatively low risk, up to hypothermia or decompressive craniectomy, interventions that are considered very risky and that have been shown to be risky based on randomized trials. And it's actually very difficult for clinicians to find the right step at the right time. And actually, if we summarize the therapies that we have, in green you have what I would say low risk therapy, or even no risk therapy, such as putting the head up 30 degrees, often with a clear physiology. And actually, those are the therapies that are usually put in what we would call lower tier. And as we go up in colors, orange therapies are a bit higher risk. Red therapies definitely have a very high risk. And some of these interventions have shown to be detrimental, such as an early decompression is something we don't do anymore. But also hypothermia below 35% has a very high risk with a with a demonstrated worsening effect on the outcome. But I will come to that. Now, we have guidelines for treating intracranial hypertension, and we used to have guidelines with a clear algorithm, where an algorithm was published, where the guideline would say, look, if this, then this. And this was true for the guidelines in 1996. This was also true for the second version of the Brain Trauma Foundation guidelines, where you had an algorithm to the guidelines. Also, something very peculiar about the guidelines, if you remember, the third edition of the TBI guidelines told us to initiate treatment when the ICP would exceed 20 millimeters of mercury. Now, if you would take this guideline into absurdity, it would mean that an ICP of 19 would require no treatment, and an ICP of 21 would be very dramatic and would have to make us do all sorts of terrible and possibly dangerous things. Of course, it is not so simple. Now, where does this threshold of 20 come from? It comes from epidemiological data, especially the studies by Tony Marmaru, where the proportion of measurements above 20 millimeters of mercury was most indicative of worse outcome. Now, it goes beyond saying that an epidemiological threshold is not the same as a treatment threshold. Epidemiology simply means that if we divide our patients into two groups and we look at the group with higher ICPs of 20, that those in general do worse than the other patients. Now, there's the latest version of the guidelines from 2017 of the BTF guidelines, where actually the guidelines were distilled up to the number of interventions for which we had evidence. And actually that is not so much. We only know level 1 evidence that we should not give steroids, and all the other interventions actually are scored low level of evidence. And there was no algorithm anymore, which means that clinicians were somehow in doubt what they had to do and how to treat intracranial hypertension at the bedside. Because this guideline is very useful because it shows us what the low level of evidence for most of our interventions is, but for clinicians it might leave you in doubt. When it comes to the threshold, I don't think the binary problem that we had with the 20 millimeters of mercury is now solved with this new 22 millimeters of mercury threshold. And so in the beginning of 2019, well, there was a lot of work already done in 2018, but beginning 2019, Greg Harley-Luke and Randy Chestnut have compiled a group of experts to make this new algorithm, because there was a lot of people asked to have a new algorithm there. And so this is the group of experts that was summoned. I was honored to be invited there, but you see it's a diverse group when it comes to geographical representation, also when it comes to gender. There were neurosurgeons there, there were intensivists there, and this is the group. This is Randy and Greg, who did a tremendous job in setting this all up. Now, when it comes to the CIBIC protocol, it's very important for clinicians to understand what it is. It means that there's a suggestion for safe and modern TBI care. Most interventions, so we voted on these interventions, and the ones that had an 80% vote in made it to the algorithm, and the CIBIC protocol is designed for a first world environment. So it is definitely not the right way or the only way or always the best way to approach trauma. It's definitely not legally binding. It's just a way to offer to clinicians some basis on how TBI could be treated, and it also should not substitute you from thinking carefully or from your own clinical judgment. But the basis of this is actually what was already in previous guideline. We have a tiered therapy based on risk, and you see I put the colors here, red, orange, and green again. So there's a tier 0 therapy, something you would do in all your patients. If the patient is more into trouble, you move to tier 1, you move to tier 2, you move to tier 3, depending on the risk of the patient. And the principle is that when possible, you use the lowest tier. Within a tier, there's no rank or order, so you should not think that certain therapies within a tier are better than the others. It's simply they're put into a certain tier because of the estimated risk benefit. It's not necessary to exhaust all modalities in a tier before you move to the next tier. And a tier, of course, can be skipped if you think you need to advance treatment and move to the next tier without doing certain interventions. And actually, the panel decided that tier 0 therapy is something you should do in all your TBI patients with an ICP monitor in place and that are sedated. What you should do, you're expected that these patients should be in an ICU, that they're intubated and ventilated, that you seriously evaluate their neurological status, you put their head side up, you give them analgesia, you give them sedation, but not for the ICP, you prevent fever, you put in a central line, you monitor end-tidal CO2, and so on and so on. All these things I don't think appear very exotic to most of you. What is not recommended, also important, is to give continuous infusions of mannitol, or scheduled infusions, to do lumbar CSF drainage, to give furosemide, steroids, to routinely use deep therapeutic hypothermia, to use propofol for burst suppression, to routinely hyperventilate, and to routinely increase the CPP above 90. Now, what is important if you want to move to a next step is that you evaluate. And the definition of clinical neuroworsening is, of course, important, but a clinical neuroworsening should not necessarily immediately lead to escalation. It should first lead to an evaluation of the patient. And so that is very important. So the inter-tier recommendation to re-examine the patients and to consider certain things that can explain the problem before moving to a next tier is very important. And so those are tier 1 and tier 2 therapies. The manuscript is open access, so I can you definitely refer you to that. In tier 2, no, this is the inter-tier, which I already explained to you, which means that you carefully re-evaluate the patient. In tier 2, we also included a MAP challenge, which is actually a challenge of cerebrovascular autoregulation in order to evaluate whether an optimization of CPP could increase or could solve the problem. Of course, this was highly controversial because there's not a lot of evidence for this, but still 80% of the experts voted it in. It should be very carefully applied and it should be looked after by somebody who is used to doing that. But basically a MAP challenge comes down to increasing the CPP for a brief period using vasopressors. And if that results in a decrease in ICP, it means your patient is autoregulating, and automatically from that you would expect that the PBTO2, if you monitor that, would improve. Meanwhile, also a second part of the guidelines has been published, which is when you monitor PBTO2 as well, which is definitely not available in all settings and which is also not recommended in all settings. But if you have PBTO2, you could use this algorithm to treat this. And there's 4 scenarios. Type A, where there's no problem, not with ICP, not with PBTO2. Type B, when there's definitely an ICP problem. Type C, when there's mainly a PBTO2 problem. And a type D, where there's problems in both situations. And for both scenarios, and I give here the type C and type D scenarios, there's also the tiered therapy, tier 1, tier 2, tier 3, based on increasing risk. Now, this is almost my final slide, where if I may recommend you something, it is that you measure and evaluate what you do. So if you decide to do CPP augmentation, for instance, it's important to measure the cardiopulmonary complications of that and also the impact that it may have on worsening of brain edema. If you decide to increase sedation, you have to realize that there's certain dangers to that and you might apply additional monitoring. If you do CSF drainage, for instance, you might increase midline shift. You also might cause infection by putting in the drain. So those are additional monitor. And especially if you move up to more dangerous therapies such as barbiturate coma, secondary decompression, or deep hypothermia, if you still want to do that in certain cases, it's definitely important to put in additional monitoring. With this, I would like to conclude my talk. I know that 12 minutes was very short to explain this very complex problem, so I would like to refer you to the 2 papers and definitely invite you to contact me should you have more questions. Thank you very much.